Echocardiography is the sheet anchor of diagnosis of hypertrophic cardiomyopathy. This picture summarizes several features of hypertrophic cardiomyopathy seen on echocardiogram. This parasternal long axis view shows the grossly hypertrophied interventricular septum and also the speckled appearance of the myocardium in hypertrophic cardiomyopathy. Here you can see a mitral regurgitation jet, which is rather common in hypertrophic obstructive variety of HCM. Left atrium is dilated due to the increased left ventricular and diastolic pressure. And this is showing the left ventricular outflow tract gradient in hypertrophic obstructive cardiomyopathy. Here the gradient is seen as 31 millimeters of mercury. The gradient is dynamic in nature so that it can increase and decrease over time. It is preload determined, and there are maneuvers which can be used to increase and decrease the gradient in hypertrophic obstructive cardiomyopathy that can be used even in the echocardiography room, like squatting, hand grip exercise, and during the procedure you can check the variation or the dynamic gradient in LV outflow obstruction of hypertrophic obstructive cardiomyopathy. This is an important question for cardiology students. Brock and Braunwald sign on cardiac catheterization. This is during a sinus beat, left ventricular tracing and aortic tracing, pressure tracings. And what happens during an ectopic beat? The pressure is lower because it's premature and left ventricle did not have much time to fill, and the gradient is also lesser. This is the gradient. Gradient is lesser during the ectopic beat. After that there is a pause. So left ventricle gets longer time to fill, and during this excitation all of the calcium released is not used. So there is some extra calcium available for increasing the inotropic